Your doctor just recommended a surgery. You said yes. But what if that decision, that one quiet yes in a hospital room, was the most dangerous thing you ever did? This is not a scare tactic. This is not an exaggeration. Every single year, hundreds of thousands of seniors go under the knife for operations that research now shows cause more harm than good. Today, I am going to tell you about 5 surgeries that doctors often recommend to people over 60, and why, in many cases, you should think very carefully before agreeing. Stay with me, because what you learn in the next 20 minutes could save your life, or the life of someone you love. Let me tell you about a man named Robert. He was 71 years old, retired teacher, loved gardening and walking his dog every morning. His knees had been hurting for about 2 years, nothing unbearable, but uncomfortable. His doctor suggested knee replacement surgery. Simple procedure, he was told. You'll be walking better in 6 weeks. Robert agreed. He never walked on his own again. A blood clot formed 3 days after surgery. He spent 4 months in the hospital. His family was never the same. Robert's story is not unique. It is happening every day, in hospitals across America, across Pakistan, across the world. And the saddest part, in many of these cases, there were alternatives. There were options, but nobody told these patients. Before we get into the specific surgeries, you need to understand something critical. The human body after age 60, and especially after 70, is not the same machine it was at 40. The heart pumps less efficiently. The kidneys filter more slowly. The immune system takes longer to respond. And most importantly, the brain processes anesthesia, the drug that puts you to sleep during surgery, in a completely different and far more dangerous way than a younger person. Doctors have a term for this: surgical risk stratification. It means that the same surgery that carries a 1% complication rate in a 45-year-old can carry a 15% or even 30% complication rate in a 72-year-old with diabetes or heart disease. This is not scare talk. This is medical science, and it is something every senior and every family member of a senior needs to know before walking into that operating room. The first surgery on our list is one of the most commonly performed on seniors, and one of the most controversial: spinal fusion surgery. If you're over 60 and you have back pain, there is a very real chance your doctor has already mentioned this, and I understand. Back pain is miserable. It stops you from sleeping, it stops you from moving, it steals your quality of life. But here is what large-scale studies now tell us. In a significant percentage of seniors, spinal fusion surgery does not reduce pain meaningfully compared to physical therapy, pain management, and targeted exercise. A landmark study published in the New England Journal of Medicine followed hundreds of patients for years. The conclusion? Non-surgical treatment worked just as well, or better, for the majority. And the risks of spinal surgery in seniors are severe: infection, nerve damage, dangerous blood loss, and something called failed back surgery syndrome, where the pain actually gets worse after the operation. Before you say yes to back surgery, ask your doctor, have we truly exhausted every non-surgical option first? Surgery number 2, knee and hip replacement. Now, I want to be very careful here, because for some seniors, joint replacement is genuinely life-changing and the right decision. But the problem is that these surgeries are being massively overperformed. In the United States alone, over 1 million knee replacement surgeries are done every year. Orthopedic surgeons are some of the highest-paid specialists in medicine. And research from Johns Hopkins and other leading institutions has found that a large number of these operations are performed on patients who had not yet tried supervised physical therapy, weight management, or corticosteroid injections, all of which have strong evidence behind them. For seniors with heart conditions, diabetes, or circulation problems, the risks skyrocket: blood clots, infections deep in the prosthetic joint that require removal, anesthesia-induced cognitive decline, and here is the heartbreaking part: Studies show that 20% of knee replacement patients are still in significant pain 1 year after surgery. Before you agree, push back. Try conservative treatment for at least 6 months. Demand it. Surgery number 3. And this one is genuinely shocking. It is called carotid endarterectomy. It is an operation on the arteries in your neck, performed to reduce stroke risk when a blockage is found. Sounds logical, right? Clear the blockage, prevent the stroke. But here is the dark truth that is only now reaching mainstream attention. For a large group of seniors, specifically those with asymptomatic blockage, meaning the blockage is there but not yet causing symptoms, the surgery itself can cause the very stroke it is meant to prevent. Multiple major studies, including the ACST trial and CREST trial, found that in asymptomatic patients over 70, the risk of stroke or death from the surgery often equals or exceeds the risk of just monitoring the condition carefully with medication. Yet thousands of these operations are still performed every year. Why? Partly habit, partly financial incentive, and partly because the guidelines are genuinely complex. If you or a loved one has been told they have a carotid blockage, please, before surgery, ask specifically, am I symptomatic or asymptomatic? What does current evidence say for my age group? Get a second opinion from a vascular medicine specialist, not just a surgeon. Surgery number 4 is one of the most emotional on this list. Open heart surgery, specifically valve replacement or coronary artery bypass, in patients over 75 or 80. Let me be very direct. For a 78-year-old with aortic stenosis and heart failure, there are cases where surgery is absolutely necessary and life-saving. I am not saying never do it. What I am saying is this: the conversation your family needs to have, but often doesn't, is about realistic outcomes. Studies show that in patients over 80 undergoing open heart surgery, the 30-day mortality rate can reach 10 to 15%. Post-operative complications, stroke, kidney failure, prolonged ICU stays, ventilator dependency are extremely common, and perhaps most underreported. A condition called post-operative cognitive dysfunction, or POCD, where patients wake up from surgery with significantly reduced mental clarity, memory loss, or confusion that can last for months, or permanently. A procedure called TAVR, transcatheter aortic valve replacement, is now available for many high-risk patients as a far less invasive alternative. If open heart surgery is on the table for an elderly loved one, ask specifically, are they a candidate for TAVR? This question alone could change everything. And now, surgery number 5. This one requires the most sensitivity, but also the most honesty. Cancer surgery in frail elderly patients. When someone is diagnosed with cancer, the instinct of every family, and often every doctor, is to fight, to operate, to do something, and that instinct comes from love. But medical oncologists are increasingly recognizing a concept called frailty, not just old age, but a measurable state of physical vulnerability where the body simply cannot tolerate the trauma of major surgery. A frail 80-year-old diagnosed with early-stage prostate cancer may statistically be more likely to die from an unrelated cause in 5 years than from the cancer itself. Yet major surgery, with all its risks of infection, cardiac events, and cognitive decline, is still recommended. Palliative care, active surveillance, radiation, and targeted therapy may offer the same or better quality of life with far less suffering. The hardest conversation any family can have is more treatment actually more care? Sometimes the answer is no, and recognizing that is not giving up, it is wisdom. So what do? You don't just say no to everything, you ask the right questions. Every senior or family member of a senior should walk into any surgical consultation armed with these 5 questions. Number 1, what happens if we do nothing or try non-surgical treatment first? Number 2, what is my specific surgical risk given my age, heart health, diabetes, and kidney function? Number 3, is there a less invasive procedure that achieves the same goal? Number 4. What does current medical evidence say about this surgery for someone my age? And number 5. Can I have a second opinion from a specialist who does not perform this surgery? Someone whose income does not depend on my saying yes? These are not rude questions. These are not questions that offend a good doctor. A good doctor will welcome them. And if a doctor dismisses them, that itself is important information. And this message is not just for seniors. It is for every son, daughter, spouse, and sibling watching right now. When an elderly loved one is sitting in a hospital room, frightened and in pain, they often cannot advocate for themselves. They feel pressure. They trust authority. They do not want to seem difficult. That is when you must step in. Go to the consultations, write down the questions, ask them out loud, bring a notebook, record the conversation if you can legally do so. Do not let the word urgent pressure you into a decision within hours unless it is a genuine life or death emergency. Most elective surgeries, even ones framed as urgent, can wait 24 to 48 hours for a second opinion. That pause could be the most important pause of your loved one's life. Here is something the medical industry does not like to talk about publicly. In many countries, including the United States, surgeons are paid per procedure. The more surgeries they perform, the more they earn. This is not a conspiracy theory. This is a structural reality acknowledged in the British medical journal JAMA and dozens of peer-reviewed publications. It does not mean your doctor is a bad person. Many surgeons are dedicated, ethical, and genuinely trying to help. But it does mean that the system itself creates a financial incentive to operate, which is why your best ally in any surgical decision is not a surgeon. It is a physician who specializes in internal medicine or geriatrics, someone trained specifically to look at the whole elderly body and say, does this person actually need to be cut open? Seek that voice. It can make all the difference. Let's talk about what actually does work for many of the conditions that lead to surgery recommendations. For back pain, a dedicated program of physical therapy, core strengthening, and targeted injections has helped thousands avoid spinal surgery entirely. For joint pain, hyaluronic acid injections, platelet-rich plasma therapy, and structured weight loss programs have produced remarkable results. For heart blockages, supervised cardiac rehabilitation, medication optimization, and lifestyle intervention have been shown in trials like the COURAGE trial to match outcomes of stenting in stable patients. For carotid blockages, aggressive medical management with statins, blood pressure control, and antiplatelet medication is the guideline-recommended first step for asymptomatic patients. There is almost always another road. The question is whether someone is willing to walk down it with you, or whether they just want to schedule your operation. I want to close with something personal. I believe every human being, at every age, deserves to make informed decisions about their own body. I believe that being 70 or 75 does not mean your life is worth less careful thought. I believe that do everything possible is not always the same as do what is best. And I believe that the most powerful thing you can walk into a hospital with is not insurance, not money. It is knowledge. Knowledge of your options. Knowledge of your rights. Knowledge of the questions to ask. Share this video with someone you love who is over 60, because it is not about fear. It is about being prepared. It is about going into that conversation with your eyes open. And sometimes, keeping your eyes open is what keeps you alive.